Good evening, everyone. Dr. Ahmed, how you can hear me? You can hear me?
Yes, yes, Doctor.
Yes, good evening, everyone. We have until now 27 participants. We will wait for all our audience to join us, at least 50 numbers. Okay. So, good evening. I am Dr. Gültekin Bakirova for our second day of online course. Special thanks to Dr. Ahmed Madi, director of this course for organization. And thanks to Dr. Ahmed Khair, who is managing the technical issues, as well as thanks to all our speakers and thanks to everyone that you joined to this program. So today we will, in our plan, four lectures, and the first lecture will be done by Dr. Ahmed Khair. He's our colleague working with us in ICU, and I am welcoming Dr. Ahmed Khair to present a very important topic related to ICU management, shock. Welcome, Dr. Ahmed, and you can start your presentation, please.
Okay, thank you, Doctor. Assalamu alaikum. Good evening, everyone. Actually, today we will start our second day of online course activity for non-ICU physician with topics of shocks and fluid responsiveness. So here, the most important now for our this topic to discuss about definition of shock and pathophysiology of shocks, types of shocks, the clinical manifestation of shocks, and we will discuss about some therapeutic modalities of shocks. So here the definition of shocks, actually we can see here that it is the shock is distribution. There is generalized maldistribution of blood flow resulting failure to deliver and utilize adequate amounts of oxygen that lead to tissue dysuxemia. So here you have to keep in your mind from the definition of shocks as a parameters numbers, we have to know it. Keep in your mind these three numbers, it's very important. Systolic blood pressure less than 90 or decreased systolic blood pressure more than 40 from the baseline or MAB less than 65. So these three numbers, you have to keep it in your mind. Systolic blood pressure less than 90 or decreased systolic pressure more than 40 from the baseline or mean arterial pressure is less than 65. In addition to that, there is an evidence of inadequate tissue perfusion, like which it can be presented by lactate, high lactate. There is also can be decrease of the urine output. All this can be as a parameters, decreased level of consciousness. So if you remember, there is what's called, before that, to go to the shock, there is something predictors, like the patient referred to the ER or from ER or from the ward. The first, you have to check the quick SOFA, which is the 3 parameters, which is decreased systolic blood pressure less than 100. And there is another is altered level of consciousness, which is secondary usually for hypoperfusion. So here, definition of shocks, as we mentioned, evidence of hypoperfusion. In addition to that, decreased systolic blood pressure more than 90, less than 90, or decrease more than 40 from the baseline, or MAP is less than 65. So here, as we mentioned just now, this is what we have to remember. So what are the factors are affecting MAPS? So here, if you can go for the affecting MAPS, you know what is the MAPS? MAP actually it is the cardiac output. So if you go the more details, is the stroke volume multiplied by heart rate multiplied by systemic vascular resistance. In addition to that, CVB. So here the stroke volume, how we can affect the stroke volume. Stroke volume actually it is affecting by preload, contractility, and afterload. Because if there is any defect in the preload, it will affect the blood pressure, or there is a problem in the contractility, like the patient who has cardiogenic shock, they will decrease, or the patient who has afterload issues. In addition to that, the heart rate, who's like the patient who has severe tachycardia, or the patient has severe bradycardia, like complete heart block. So they will have an issue with, they will reflect on mean arterial blood pressure. While the systemic vascular resistance, there is, especially who have got vasodilatation, they will get hypotension because systemic vascular resistance, when it's decreased, so it can cause more hypotension. Like the patient who has distributive shock, we will discuss later about this differential. In addition to that, the CVB, it's a parameter. So here again, the shocks is inadequate blood pressure or inadequate tissue perfusion with or without evidence of hypertension. Because as we mentioned, like decreased blood pressure more than 40, for example, but his baseline is 160. If the patient go for 110 systolic, in addition, there is evidence of hypoperfusion. This is mean sign of shocks. So the other parameters, tachypnea, tachycardia, organ dysfunction like hypotension, oliguria, or altered level of consciousness. So lactate usually it's a good marker for recognition of shocks. But remember, hyperlactemia is not only caused by shock, it can be, there is other types can cause the hyperlactemia. So keep in your mind the other differential. So here, shock definition. Actually in adult, as this in sepsis campaign just published recently in, regarding the COVID-19 as urgent guidelines, they are saying persistence hypotension despite the fluid resuscitation required vasopressors to maintain the MAP more than 65. In addition to that, lactate more than 2. So hypotension and requirement not responding to IV fluid, requiring vasopressor to maintain MAP more than 65, and there is evidence of hyperlactemia, which is more than 2. So which of the following patients should be, we can say this is in shock status. So I will just keep it in polls now. So which of the following is in shock status? A 30 years old male who has blood pressure 80 by 40, or when he received the fluid, he got systolic blood pressure 100 over 65 with normal lactate. The other scenario, he required inotropic support, the same, but his lactate is normal. The last one scenario, they give not responding to IV fluid, required vasopressors, and lactate is high. So we get until now 30, we need more, please. Okay, all right. So 93% they select the proper answer. So here, what is the pathophysiology for shock? Remember, CBR, capacity, which is inadequate volume or there is a problem in pump, or there is a problem in resistance. Okay, so if there is inadequate volume, like the patient in hemorrhagic shock, is in hypovolemia, dehydrated, so all these it will affect. Like if the patient has a heart failure, there is pump failure, whatever the cause of this heart failure. It's so there is pump failure, like in COVID-19, they might develop cardiac failure secondary to the sepsis, or they can develop secondary to myocarditis. So it can be. Resistance, it's dilated circulation. As we mentioned just now, systemic vascular resistance, it will be decreased, like the patient who has, for example, distributive shocks. They have distributive shocks secondary to, for example, the infection, the septic shock. It can be the cause. So all these, just to keep it in your mind, any one of them, it can affect the shock and can induce shock. So this is, the pathophysiology is very important to be understand the underlying cause. So here there is the patient who has a problem with the volume. If you can see the first one, you will see here the tank is it's okay, normal. This is the normal actually. But if the patient has hypovolemia, you will see the tank is decreasing the volume. Like if the patient has distributive, because the resistance is low, so you will find it's vasodilator, the tank width is increasing. And if you go to the last one, the heart failure, you will see there is no vasodilatation actually, but the issue for them, it's full of fluids. So here we will, this is very important, the fluid assessment, it's very important to understand the underlying cause of shocks. So here the two types of shocks, you have to keep it in your mind. This is very important to differentiate, as make it as approach for you. Distributive shocks or resistive shock. Distributive shocks, usually they have high cardiac output, but they have low systemic vascular resistance. As we mentioned just now, who has distributive shock, they have low systemic vascular resistance because it's vasodilator. In addition to that, they are trying to compensate with high cardiac output. This example, like septic shock, anaphylactic shock, neurogenic shock, or adrenal failure. While in resistive shocks, we have, for example, hypovolemic, cardiogenic shocks, or it can be obstructive shocks. So all these three types, they will have resistive shocks called, as it's called, but what they have also in the cardiac output, it will be low cardiac output. But they are trying to compensate in the opposite side here with high vascular resistance, because the heart is not pumping properly, because there is no good volume, no stroke, the stroke volume is low, so they are not pushing the heart. Like patient cardiac turbulence, the heart cannot pump good stroke volume. Or the patient in cardiogenic shock, they could not also give a good stroke volume. And even the hypovolemia, the preload is low, there is no stroke volume. So the body will try to compensate by high systemic vascular resistance, but there is low cardiac output. So this is very two important categories. It should be kept in your mind: distributive shocks and resistive shocks. Distributive shocks, keep it in your mind: high cardiovascular, high cardiac output. Resistive, have low cardiac output. So this scenario, we can just review the scenario together. This a patient, he has clinically, he has warm, dry peripheries, tachycardia, bounding pulses. But if you go to the his heart, the pump is high pump. The cardiac output is high. But if you go to the systemic vascular resistance with advanced modality, you will find the patient has vasodilatation. There is low vascular resistance. At the same time, the patient has the low volume capacitancy. So what do you think about the types of shocks here? You can just write it in the chat channel, please. So is it here distributive, or it is resistive shocks?
It's distributive shock.
Okay, so distributive shock, it can be because here, as we mentioned, how it will be both together? So someone mentioned both, how it will be. So with this parameter, actually, it is distributive. It will be distributive shocks, but it can be sometimes both, but not in this scenario. Actually, we need more, but this is as initial. So here, distributive shocks. What's the example for that? As we mentioned, anaphylactic, neurogenic, adenosine crisis, liver failure. All these it can be as causes for that. So here we will go to the other scenario. So here the other scenario, they have low pump and high vascular resistance. At the same time, they have low volume capacity tank. So what is the main category here? We can just write it in the chat, distributive or resistance, or resistive, I mean. Okay, resistive shock actually. So this is the resistive shocks. What is the example for that? We said it can be cardiogenic shock, it can be obstructive, or it can be hypovolemic shock. So here there is another scenario. Actually, it's if you see here, there is low pump, but here there is high vascular resistance, and there is here high volume capacity. So if you compare to the previous one here, there is low volume capacity, which is going with hypovolemic. While in this case, here is high volume. It's the same, low cardiac output, high vascular. So it's distributive or resistive. And what's the type of resistive? Obstructive. Why it's high volume capacity tank? Yeah, it's cardiogenic. As we said, it's volume overload. Usually there will be cardiogenic shock. So here there is the same, actually, the same example, just for the time here. The obstructive, that one is example for obstructive. So just we'll proceed for the next. Here again, the types of shocks, as we mentioned, there is resistive and there is distributive. Here we will go the details in resistive. So here there is three main categories: hypovolemia, cardiogenic, and obstructive. So here in hypovolemic, there is an example for that, who has hemorrhagic, he has dehydrated, secondary to the nausea, vomiting, diarrhea, or the patient he has burn, he has third space occupying, or he has high vascular permeability. Like the cardiogenic shock, it can be because from the wall itself, there is the MI, so it's causing myocytes infarction, so it will decrease the ejection fraction, or there is a problem with the valve failure, it's mechanical obstruction, or the patient has severe arrhythmia and myocarditis. So because severe arrhythmia, like the patient is tachycardia or complete heart block, all this will affect myocarditis. As we mentioned, the COVID can cause myocarditis. Also, it is possible. But in obstructive shock, here it's like the massive PE or cardiogenic tamponade or constructive, because how it will be the mechanism of the obstruction to causing shock. Like massive PE, what will happen in the pulmonary trunk? It will be obstructed. So the preload, it's coming to from the inferior and superior vena cava, going to the right atrium, then to the right ventricle. But when go to the pulmonary artery, it's not going because there is an obstruction. So here, this is it will cause on the left side because there is not enough amount of blood going to the left side of the heart, so decreasing the cardiac output. In addition to that, if the cardiac tamponade, there is in the pericardium, there is a lot of blood around or fluid, whatever the cause of tamponade, it's causing equalization. Cardiac tamponade, by definition, it's equalization of diastolic pressure in 4 chambers. So if there is equalization of these, so the stroke volume will be low. So this is a mechanical obstruction. Another constrictive pericarditis, it will be chronic, usually tension pneumothorax. Also, it can cause a mediastinal mass. So here just we will go for the surviving sepsis campaign guidelines. Actually, this is published recently. We select here in this lecture to discuss about what's the type of fluid we are needing, what is the vasopressor we are requiring for these patients. So these types, because we are talking mainly in matter of COVID-19, shocks in COVID-19. So here the recommendation actually, if we need the IV fluid, which types of IV fluid as resuscitation we need? Here we say the crystalloids. Keep it in your mind. The crystalloid is better than, it is superior than colloids in this recommendation. Okay, because there is no difference, cost effective, it's very important. So we are going to use a crystalloid. From the crystalloids, we have 2 types. There is balanced or non-balanced. Like non-balanced, like normal saline, the 0.9% of sodium chloride, or just 1 second, please. Okay, or we can use the crystalloid. So the balance, we said there is balance or non-balance. The balance is a crystalloid like ringer lactate, so we can use it, which is more preferable. And there is one trial they are preferring, especially in the septic shock, but in the cardiogenic shock, there is no difference. But in septic shock, mainly they are preferring to use the balanced crystalloid because there is less hyperchloremia causing, and it's less risk of acute kidney injury also. So the others, if we give fluid resuscitation and the patient required vasopressor, which type of vasopressor as the initial or the first line of vasoactive agents? Number 1, we need norepinephrine. Norepinephrine is the first line. What is the second line? The second line we can add vasopressin. So if the patient has shock, they are not recommending to start the patient in dopamine, because the dopamine, there is arrhythmogenic, it can be, so it's not the first line of treatment. But there is some consideration, maybe we can start dopamine as temporary time, like the patient is in ward, he has no central line, or in AR, still central line not inserted. From the literature's review, they are preferring dopamine as peripheral for a few hours until the central line is secured. But in general, as the first line is norepinephrine, the second line vasopressin. Dopamine is not recommended for the distributive shock. So there is, just to remember, there is some types of fluid, actually they are not recommending to be used, like starch, or this is the starch is not recommended actually to be used. So in refractory shocks, like the patient he require more than 2 inotropic support, more than 2 vasopressor supports, we can start some steroids, like the total either infusion or boluses, 200 milligram per day. So this is the scenario. 45-year-old male has a blood pressure of 80 by 40, and he received fluids. His lactate is 4, but still not responding to the fluid. Which vasoactive agent you will start? So you can just writing in the polls. Can you answer now, please? Okay, so the majority they are saying noradrenaline. Just there is a comment regarding noradrenaline. Yes, it can be used as a peripheral line with low dose. Some they are saying 0.08 or 0.1 can be used. But if you go to some literatures, they make dopamine is superior to NORAD in case of peripheral line. So actually both can be used, but some literature they recommend the dopamine as a peripheral line. So how here we will go to the other parts, which how could we evaluate the fluid responsiveness? So here the fluid responsiveness, actually any patient he has, not all the patient they will be fluid responsive. Just keep in your mind. Sometimes you are starting fluids. This is a drug you might harm the patients. So not all the patients just give the fluids. You can give him the fluids, but there is a limit, like especially the patient who has, for example, he has ARDS or he has cardiogenic shocks, so cannot be deal like the other patient who has hypovolemic shock. So you have to assess something called the fluid responsiveness. What is the volume status for this patient? So how we can assess the volume status for the patient? We have a lot of methods we can use it, but just we will focus for some of them actually. Here there is inferior vena cava assessment, like ultrasound, bedside, you can do it. Assess how is the IVC collapsibility and how is the size of inferior vena cava. For example, it's less than 2, going with the hypovolemia, with new and collapsing during inspiration, expiration. This is very important to be assessed ultrasound. The lactate level, like you give the patient initially, he has lactate, it was 5. You give 1 liter of ringer lactate. After that, it's going to 3 after 3 hours or 2 hours. So this is going with the fluid responsiveness. There is decreasing, significant decrease. The other way we are using there is called fluid challenges. Fluid challenges, there is 2 methods. Either you, for example, you give 500, or there is called many challenges like 50, 100 ml, but this is, you need invasive monitoring. You will give 100 ml bolus, and you will see how's the cardiac output, the waves, but this is need invasive cardiovascular monitoring, so it's not the usual. But you can give the fluid and to see. Mechanical ventilators, we will not go for that because this is advanced actually for this course. The others, we can see the stroke volume variation and pulse pressure variation. Pulse pressure variation, the patient, most of the patients who require vasopressor in ICU are inserting A lines for them, and we can see the pulse pressure variation. If it is wide pulse pressure variation, but should be sinus rhythm. This is important, and the tidal volume should be more 8 ml per ideal body weight kg. So it's this is very important. So you can see if there is significant variation, you will consider this patient fluid responsiveness, or the other passive leg raise. So the passive regress, actually, there is some important things, like you have to keep the patient in this 45 degree. After that, you will, ideally, you should not touch the patient at all. You should not awake the patient. Just you will turn the bed to put the head flat and to raise the legs 45 degrees. So as actually it's 90 degree changing in the positioning. Here, if the patient fluid responsiveness, there is the blood pressure will be increased and the cardiac output will be increased. And then after that, you will retain the patient again. Once you retain the patient again to the same position, it should be go to the baseline. So this is go with the fluid.
We have another 3 minutes.
Okay, already we are about to finish. So here we will go to the other scenario. 18 years old female admitted to the hospital electively for nasal. Actually, we'll just proceed this case. So here we will go for. So you can see this is the ultrasound, the bedside ultrasound for inferior vena cava. So it is here. It's important to see the right atrium. Then after around 2 centimeters away from the conjunction, you can just keep it here. We are putting in the in mode. During the expiration, we will just measure how many centimeter. Then you will measure also during the inspiration. There is collapsibility index. Actually, it should be more than 18, or just simply we can collapse more than 50%. Just you will house the end during what is the maximum diameter and the minimum diameter. It should be around more than 50%. Here, there is if the patient has arterial blood pressure or advanced monitoring, just to calculate variation, we will just, because this is advanced, we will proceed. So here, 72 years old male, obese, diabetic, hypertensive, with a history of ischemic heart disease. He was admitted with the COVID-19, query COVID-19, septic shock, intubated, respiratory distress. He developed hypotension, 75/45 degrees level of consciousness. So here there is how to assess the fluid responsiveness. As we mentioned, now we can just go for passive phrase leg raising. Actually, it was not improving that much. CVP, it was around 12. Vena cava, it was not collapsing. Lactate, it was 2.8, not a change after we give fluid challenging also. And pulse variation is 11. So this is considered as not fluid responsiveness. So when you are checking the fluid responsiveness, try not to take from one parameter, take it from different views, especially if you don't have advanced monitoring like echo machine or volume view. This is give you better view. But if you don't have these things, you have to assess in different way, just to be more confident about the fluid responsiveness. So take home message. Definition of shock: the resistance hypotension despite volume resuscitation requiring vasopressor to maintain maps more than 65, and serum lactate, it was more than 2. Types of shocks, as we mentioned, there is resistive shock and distributive shocks. Keep in your mind, fluid is a drug, not all types of shock are fluid responsive. So first line of vasopressor is norepinephrine, then vasopressin. So the recommended IV fluid, balance crystalloids. And thank you. If you have any question, just you can raise the hand, or you can write in the chat.
Thank you, Dr. Ahmed, for detailed and same time easy to understand definition and pathophysiology of shock. And if someone have questions, please you can raise your hand or write a question in chat.
There is a question from Dr. Ali Zahrani about the role of BBF in shock patients. Actually, as you mentioned, this BBF, protein plasma fluid, is a colloid. As the recommendation is not the first line. Actually, it's common use, common practice, but as a recommendation, there is no difference between balanced crystalloids and BBF. BBF is very expensive, by the way. But the IV, the balanced crystalloids, the 500 equal 8 riyal, but BBF around more than 300 or 400 riyal. So it's a big difference. What kind of crystalloid should I give? Actually, they prefer balanced crystalloids like ringer lactate, actually, which is the common we have in Saudi Arabia. So there is someone who raised the hand. There is no one now. So any more question?
Okay, thank you, Dr. Ahmed. And we are moving to second presentation. Second lecture, pathophysiology of COVID-19, will present by ICU consultant, Dr. Waqas. And Dr. Waqas, kindly can you share a presentation and start, please.
Assalamu alaikum, everybody. Thank you, Dr. Gultakeen and Ahmed Kohel. Can we see the slide?
Yes, Dr. Waqas.
Okay. Bismillahirrahmanirrahim. Welcome. This is a little bit complicated lecture, and this actually is a theory which is presented by a German anesthetist. His name is Gattinino, and it is very much in news nowadays. And he actually changed the perspective for management of ARDS. We'll go through the slides and inshallah, we'll try to grasp the concept. So these are actually not the guidelines, but these are his observations. So as we know, we are managing patient nowadays, not on based on guideline, but mostly on the personal experiences, and then they are putting them in the guidelines. So let's proceed. This is the most famous slide you'll find almost in all presentations of the COVID-19. And this is presented in New England Journal of Medicine, and it shows the pathophysiology of this SARS-CoV-2, and it has spike protein, and these spike proteins, they attach to the ACE2 receptors, and finally they get into the cells, endocytosis, and replication, regulation, and finally destroy the cells. And the second effect, because it controlling the ACE2 receptors. So this will be down-regulated. And after down-regulation, what will happen? The angiotensin 2 level will increase. We'll come to next slide and I will explain the further details of this mechanism. And this angiotensin 2, finally, it will cause acute leg injury, adverse myocardial remodeling, vasoconstriction, vascular permeability. Okay, this is a further detail of this one, angiotensinogen. On this, renin acts in the kidneys and it works to the angiotensin 1. Angiotensin 1 goes converted to angiotensin 2 by ACE1 receptors, and this angiotensin 2 usually it binds to the ACE2 receptors and it converted to the good protein, which is angiotensin 1 to 7, and it is vasodilatory, anti-inflammatory, and anti-proliferative effect. So once the this COVID-19, SARS-CoV-2 binds to the ACE2 receptors, the non-availability or less availability, this pathway is converted to this pathway. So angiotensin 2 now has the option to affect angiotensin 1 receptors and angiotensin 2 receptors. Angiotensin 2 receptors, again, this is somewhat good vasodilatory effect, anti-proliferative effect, but angiotensin 1 receptors have the vasoconstrictive effect, fibrotic and proliferative. So actually, the destruction of the lungs or the pathophysiological process in the lungs is the imbalance between the activation of these two receptors, 81 and 82. This picture shows as ACE2 receptors are present, as you can see in the brain, in the lungs, in the kidneys, in the intestines, and of course testicles. But the most effects which are documented on the brain, kidney, lungs, and intestines. Okay. This actually, we can divide the disease course according to Gattinelli in hyperacute phase, indolent phase, and biphasic. Hyperacute phase, severe hypoxemia will lead to acute breathlessness, and finally the patient will be intubated because of the respiratory failure. The other type is indolent phase, where the course is gradual, a little bit moderate, and moderate of work breathing, and patient usually escapes the intubation and mechanical ventilation. The third type, or the what happens, that two phases come together. First, it starts with the indolent course, and which stays for 5 to 7 days, and suddenly then acute deterioration with hyperinflammation, worsening respiratory failure, and finally we get the infiltrates and consolidations, collapse, everything on the X-ray or CT. Sorry. As you can see, the X-ray, these are the minimal changes in the X-ray to full-blown ARDS with collapse of the lung. So this can vary. The same things is shown by the effects of COVID-19 on the CTs. Different like this. Here we can get consolidation. Here we can see this crazy paving appearance along with this the ground glass opacities. And here even they have noticed few cases of mediastinal lymphadenopathy with COVID-19. Okay, this is the gentleman, Luciano Noni, who has presented his concept about the management of ARDS in COVID-19, and he's saying the every chest infiltrate in the COVID-19 case is not ARDS, and we should change our management plan based on the parameters which he described in his thesis or articles and interviews. So we'll go through this now. In American Thoracic Society Journal, he presented that COVID-19 does not lead to a typical acute respiratory distress syndrome. And this can be pneumonitis and can be typical ARDS. According to this article, he presented that he classified the factors into A, B, and C, and he says in the factor category, they say A, they say severity of grade of infection can affect or modify the disease pattern. Second, how the affected person responds to the infection, how much physical reserves he has, and what are the comorbidities he's having. Now, if the patient is intubated and ventilator, then the lung and ventilator interaction also plays a role, and overmanagement also put a part in this pathophysiological process to be worsened or to improve. And there is how much time passed between the onset and in the when the patient observed in the hospital. So these three ABC were modified and classified and presented in a bit and a good tabulated way by Massachusetts General Hospital guidelines. And they say that if one of the epidemiological factor along with one of the vital signs factor or one of the labs factor, any epidemiological factor with one vital signs or epidemiological factor with one lab factor, then there's a high probability that patient the chest infection will worsen and the high risk of progression will be there. What are these epidemiological factors? If your age is more than 65, patient is having pulmonary disease already. He is having chronic kidney disease. He is having uncontrolled diabetes. He is having hypertension and history of cardiovascular disease, MI, heart failure, or he is have overweight with BMI of more than 30. He is taking of monoclonal antibodies, or patient has undergone some kind of transplant, or he's HIV positive with CD4 of less than 200, then these epidemiological factors play a major role in the progression of disease. Along with if patient is having respiratory rate of more than 24 or heart rate of more than 125, saturation less than 93, PF ratio less than 300. So these are signs of severity in terms of vital signs for any patient. So if one of these factor is present along with epidemiological factor, we can say there is high risk of progression. Or this epidemiological or labs. D dimer is more than 1000, CK twice upper limit of normal, LDH of more than 245, elevated troponin, CRP more than 100, and of course lymphopenia or ferritin more than 500. Okay, this will further discuss in one more diagram. But here actually there's what happens. In the lungs there is imbalance in the VQ ratio, and there will be making of microthrombi, and finally there is shunting. All these factors are the main headings or main factors which can affect the ARDS picture or pneumonia in the COVID-19 patient. The other factors, this neurotropism, and because of this, COVID-19 affects the brain, and patient can have anosmia, patient can have delirium, it can have cognitive problems, and even the midbrain involvement can cause cardiorespiratory arrest. And the third factor, as we mentioned before, this is the interaction between ventilation and mechanical ventilator and the patient. So this could be high VQ or low VQ, low elastance versus high elastance, recruitment, high possibility of recruitment or the recruitment possibility is low. Patient can have wet lung or dry lung, and patient, if you give beep, patient will be more responsive or less responsive. We'll describe in next. So these factors, they interact each other, and finally time related disease pattern will be of two types. So they mentioned it L and H. L and H I will explain further. Here actually this is the explanation of the previous slide. Actually there is high perfusion and low ventilation. So what will happen? The VQ will be imbalanced and patient will have severe hypoxemia. Because of hypoxemia, you try to take more breath and work of breathing will increase. Second, as I mentioned, this COVID-19 has neurotropism and receptors on the brain. It will cause increased respiratory drive, and once increased respiratory drive would also increase the work of breathing. So once hypoxemia and neurotropism, increased work of breathing, what will happen? Patient will have increased tidal volume. Every breath, he will try to inspire more and more air into the lungs. And what will happen? It will lead to the patient self-induced lung injury. Because, of course, if we give tidal volume from outside by mechanical ventilator, and it is beyond the capacity of the lungs of the patient, it will cause damage of the lung. Same thing happens, and patient actually doing harm to himself, and that's why he's calling by increasing work of breathing, increasing tidal volume. That's why it called patient self-induced lung injury. The other direct lung injury by COVID-19 itself. As I mentioned, it enters the cell, increased permeability, everything, and damages the lungs. So acute lung injury. These two factors affect the lungs. On the other hand, if patient goes into the sepsis, of course, the sepsis will increase the metabolism, and this will add to the work of breathing, and same cycle will start and will end into the patient self-induced lung injury or acute lung injury both. The other mechanism, they have observed at the micro level that COVID-19 causes microthrombi formation. And after microthrombi formation, what will happen? The gas exchange area will be reduced and increased dead space. Third, once the collapse and ARDS happens, there will be shunting. So oxygenation will not be proper. So this is in-depth view of pathophysiology, what's going on in the lungs. So main things are this hypoxemia, along with neurotropism, increased tidal volume, patient self-induced lung injury with direct injury by the coronavirus, sepsis, increased metabolism with increased work of breathing. So here we start, as mentioned, impaired gas exchange, lung elastance. Then what will happen? Hypoxemia, increased respiratory drive, patient will increase, it will cause increased tidal volume of the patient. And what will happen? Patient self-induced lung injury. And what will happen? It will cause increased swings in the esophageal pressure, tracheal pressure. Finally, capillary leak, and lung, which was dry before, will develop the go into the edema, and the lung edema, and finally further compromise impaired gas exchange. And this vicious cycle goes on, and what happens? That dry lung is converted to the wet lung. So this type of lung injury is converted now to another type of lung injury, and this is L type and H type. Further, what is L and H, why they are given the name, we'll describe. Now go back to the previous slides, and this is another illustration of the same pathophysiology, hypoxemia. It will cause dysregulation of the pulmonary perfusion. So what will happen? Patient lung will have been low elastance, low perfusion, as described earlier in the previous slide, low recruitability, and limited peer response. Because it's all low issue, so they labeled it as phenotype L. This, in simple way, this will be dry lung. Now, what will happen? There are pulmonary microthrombi or severe hypoxemia. Finally, this dysregulation and the shunting process will take over. And what will happen? The patient dry lung will go into the wet lung, and this is the typical ARDS. This is what he wants to say, that the all this hypoxemia or respiratory failure in COVID-19 is not typical ARDS. So here we see this is low elastance, low VQ, low recruitability, and limited response to PEEP. But when it turned into typical ARDS, it will be high lung elastance, high recruitability, high right to left shunt, and high PEEP responses. This is typical ARDS, and this is atypical ARDS. So according to him, the management should be different. So that's why, because of this HH, high, 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 and high, they given the name of this phenotype H, and this one given the name of phenotype L. And because of disease severity, level of intrathoracic pressure by increased tidal volume, this phenotype low by over management or patient itself can be converted to phenotype H of typical ARDS. So this is the concept of pathophysiological process described by Gattino. Actually, this concept of patient self-induced lung injury was described in 1938 and 1988 by Barak and Mascheroni in these respectable journals. So they reapplied this concept now in the COVID-19 pathophysiology. Okay. Now they have observed actually this article or his research is based on the cases. So of course he described one case in his article that this patient with the PF ratio of 95, and we can see most of the lung is aerated. Many few patches are there, and the lung weight was 1100 only, and receiving oxygen with inspired oxygen fraction of 0.8. And non-aerated tissue virtually was almost zero. Most of the lung was aerated. Now, after 7 days, this was L type. Now, this after 7 days, PF ratio is not too much change from 93 to 84, but you can see the CT, it is destroyed totally now. What's going on? The aerated tissue is very less. Most of the lung is opacified by fluid, by infection. And so this is ARDS. So they say this H type is converted to L type by the disease itself or patient self-induced lung injury or by our wrong management of ARDS where we didn't need high P. The high recruitability was not required and we were doing wrong management actually. So one type can be converted to the other type. So he gave a way to approach the patients. What he did, he given 15 liter of oxygen to all the patients who come to the ER and determine the severity of the shunting. If the given 15 liter of oxygen, he noted if saturation is more than 95%, then he considered it mild. And if by 15 liter of oxygen, saturation is not reaching more than 95, he considered moderate to severe. For mild cases, he suggested that we can use this high frequency nasal cannula or CPAP in controlled environment. So what is the controlled environment? That this should be the in the negative pressure room and PPE should be used and the continuous monitoring of work of breathing. Okay. Regarding work of breathing, the simplest way is the central line insertion is subclavian line and subclavian vein, and we'll see the swings in the central vein, venous pressure, inspiratory, expiratory, and these swings difference is 10. He considered this as a low work of breathing, and he said such patients can be managed with high frequency nasal cannula and CPAP. And for example, if we see the work of breathing is increased and swings are more than 15 centimeter of water difference, then he asked that we should intubate the patient. So based on work of breathing, he further classified that which patients can be used for high frequency nasal cannula and CPAP in the controlled environment. And the patients who have high work of breathing, it should be intubated. Once patient with the high work of breathing intubated at this level or initially at the first stage, what we will do, we'll keep the tidal volume 8 ml per kg of predictive body weight, PEEP of 8, and RR to be established according to end tidal volume, and you can say end tidal CO2 of 35 almost. And what will be targets on the mechanical ventilation? We need a saturation of 90 to 94, PO2 around 60, PCO2 of 45, and blood pressure to be kept less than 28. So after achieving this target, after these settings, we'll see the driving pressure. Driving pressure, if less than 15, it means we are doing good, and most likely the patient is having a low phenotype of this COVID-19. So we can keep the tidal volume a little bit high, like 8 ml per kg, at the same at which we started this journey. If, for example, if we are not getting our driving pressure less than 15, what we can do, we can reduce the tidal volume 6 ml per kg predicted body weight. And then further, if we achieve the target of saturation more than 90 and FiO2 not reaching 70, we'll continue. Otherwise, if we are not getting our target and saturation stays below 90, and FiO2, we have now reached the level of 0.7 or 70%, then we can use neuromuscular blockade. And we can gradually increase the P from 8 up till 15 centimeter of water. And at this point, till this point, we have the targets of saturation 1994, PO2 same 56, PCO2 45, pH 7.3, blood pressure less than 30, and of course, driving pressure, as I mentioned before, less than 15. For example, we have done neuromuscular blockade and we had TC cut of PEEP of 15 and still the saturation less than 90, FiO2 more than 0.7, then we have to check the compliance. And this compliance in intubated ventilation will tell us with which phenotype we are dealing with. For example, if compliant lung more than 40, so we are dealing with phenotype L. So patient has low elastance, low recruitability, and don't raise the PEEP more than 8 to 10 and keep the tidal volume 8 ml per kg to a little bit higher range. It will not damage the lung, but if you see the ARDS protocol, they recommend the 4 to 6 ml per kg. So that's the reason he divides the phenotypes into L and H type, and he says don't damage the lung by opting the typical ARDS protocol. So here we can see if complies more compliant lung, we'll label it as low type, and we'll use because it is low recruitable lung and low elastance, we can keep the tidal volume 8 ml per kg and PEEP 8 to 10. Otherwise, if not compliant lung more than 40, then what we'll do, it will be labeled as phenotype H, high elastance, high recruitability, prone responsive. Patient will be prone, PEEP responsive. High PEEP will help here more than 8 to 10 up till according to ARDS protocol. And we can use APRV mode also. For example, we have achieved, we are entered the pathway of and where a typical ARDS is there, and hypoxemia still not responding to prone position or APRV for more than 6 hours or sooner. If there is multi-organ failure, then we should call the ECMO consultant or the center where ECMO facilities are available. For example, if the ECMO consultant says, okay, this is a candidate for an ECMO and we can help the patient by ECMO, then we should arrange for VV ECMO or transfer to the center where ECMO facility is available. Otherwise, if patient with this more than 6 hour prone positions and APRV more than 6 hours and it's not improving, and even ECMO center is refusing that this is not a candidate for ECMO, then we should decide about the code status of the patient, and we should discuss with the family and with our team that what are the possibilities and how should we should continue the supportive care, or we should go for the DNR. So in summary, the early recognition of hyperacute disease is important because it will lead to immediate intubation and then short and judicious use of CPAP and IV for a hemodynamically stable patient, he recommends. And of course, we should be aware of work of breathing and biphasic course, and early differentiation of two types, L type and H type, because this will change the plan of management. And again, we should be hopeful always, and although there is disappointment while we are managing the patient, but of course the hope is infinite and disappointment is finite. So just keeping this thing in mind, and thank you very much.
Thank you, Dr. Vakas, for speech and updated informations. And I think we have questions. So Dr. Ali is asking question. CPAP in our cluster pathway is not allowed. So we can proceed to intubation.
That's why I think I shared this slide again. I put it in the start. The concept presented in this presentation are not guidelines to manage the patient, but only theoretically presented by this gentleman and an anesthetist, and he is discussing the pathology of the lungs. So follow the protocols and guidelines according to MOH. But still, this is not the end, and in the initial phases, this high frequency laser cannula actually still, and CPAP in the initial guidelines of WHO, and high frequency nasal cannula, I think there is fluorenidril also in France, I think so, they recommend. But because we're in Saudi Arabia, we have to follow the local protocols MOH, so we'll stick to that. But I think this presentation is to give you the concept that sometime high PEEP, and the low tidal volume, this can affect the patient more than anything else, because the lung is, if it is compliant, of course, we don't need too much beep and like this. So that's why I think keep in mind while you're treating the patient in the initial phases. Regarding high frequency nasal cannula and CPAP, just follow the local protocols because, of course, there is a high risk of transmission of infection with high frequency nasal cannula CPAP. That's why Gattino even said this should be done in the controlled environment like negative pressure room, full PPE, and only then you can use. But still, I think better not to use if it is not recommended in our guidelines.
Another question, does H type be in younger patient while L on old patient? And does the COVID has restrictive lung disease picture?
Sorry again.
Does H type be in younger patient while L type on old patient? And does the COVID has restrictive lung disease picture?
No, it actually age factor. This is related to the progression of the disease, and most, of course, if age more than 65, there's progression of possibility of progression of disease will be high. But they have not labeled this L and S type based on age. It can be in any age. It depends on the picture of the X-ray and CTs, one. And second thing, when if you have intubated the patient, then the parameters from the ventilator, you can judge that what's going on actually with the patient. So L and S type can happen in any age. But of course, progression of disease higher in age more than 65. So you will find mostly typical ARDS in age more than 65.
Thank you, Dr. Fagas.
Thank you very much, Dr. Kultuki. Thank you, Ahmed Kuher.
Next, lecture will be presented by Dr. Basim, our senior ICU consultant, and he will talk about mechanical ventilation. Welcome, Dr. Basim, and please share your lecture.
Assalamu alaikum. Can you hear me?
Yes, sir.
Thanks, Dr. Waqqas, Dr. Gultakin, Dr. Madi, Dr. Kuhail, and everybody for coming. I'll try to make this short, and as you may noticed, I changed the subject from basics to essentials of mechanical ventilation. This is because I tried to cut short whatever I thought you'll not be interested in, being non-intensivists probably or possibly serving in ICU for some time. So starting with the introduction, I always like to start with this question. This question, I feel, illustrates the most important thing that I will always like to deliver in this lecture. And the question says, what are or is the defining feature of mechanical ventilation in your opinion? Is it oxygen, pressure, definitive airway, which means endotracheal tube or tracheostomy tube, or sedation? Any of the above, none of the above, all of the above? Please share your views. What is the thing or things that are essential and core to mechanical ventilation? Without it, there's no mechanical ventilation. I always find it difficult to read the. I don't know where to get the comments from. 2 and 4, all of the above. 2 and 4, pressure and sedation, all of the above. B, pressure only. Just share what you think. This is not an exam. Can we deliver mechanical ventilation without oxygen, without pressure, without definitive airway, or without sedation, or none of the above? 3 and 4, definitive airway and sedation. All of them are necessary. Okay, all. Any more ideas? all. Okay, apparently most of us think they're all. So let's go through them one by one. Sedation plus minus neuromuscular blockade. Could we deliver mechanical ventilation without sedation? Obviously, yes. On non-invasive mechanical ventilation, we almost never apply sedation. But even on invasive mechanical ventilation in a patient who is highly cooperative, sometimes we can deliver mechanical ventilation without sedation. So sedation, although very commonly used in mechanical ventilation, but it is not a core defining feature. It is not necessary to mechanical ventilation. Definitive airway is the same. Definitive airway means endotracheal tube or tracheostomy. And obviously in non-invasive mechanical ventilation, we use neither of these. So we can deliver mechanical ventilation without definitive airway. On the other hand, sometimes patients with definitive airway, especially tracheostomy tube, are not ventilated. They have a definitive airway, but they're not ventilated. So they're not linked, although pretty much associated. Oxygen is the same. If a patient has no problem with oxygenation, his problem is only with airway or ventilation. So we can ventilate them on room air, oxygen 21%. But pressure is the essence of mechanical ventilation. Without pressure, there's no mechanical ventilation. So mechanical ventilation is always about pumping air under pressure into the lungs and then allowing it to flow passively outside of the lungs during the expiration. If we remember physiology, this is exactly the opposite to physiology. During normal breathing or spontaneous breathing, we inhale air under negative pressure and then let it out under zero pressure. So this keeps the alveoli under 0 to negative pressure normally. Now on mechanical ventilation, alveoli are always under positive pressure, more positive during inspiration and less positive during expiration, but always positive. Applying positive pressure to the alveoli constantly is unphysiological and essentially harmful. This is the most important point I want you to take home from this lecture. That mechanical ventilation is inherently harmful. We apply it because of necessity. Mechanical ventilation is not a treatment, it's just a bridge or support until the true treatment works. For example, if a patient has community-acquired pneumonia, bacterial, then the treatment is not mechanical ventilation, and he developed respiratory failure necessitating mechanical ventilation. The treatment is not mechanical ventilation, it's broad-spectrum appropriate early antibiotics. But to avoid the patient dying before these works, because they would take a few days, then we would apply mechanical ventilation. Understanding that mechanical ventilation is not a treatment will take us to understanding that it is not dose dependent. It is not the more the better, and normalizing the ABG is not at all necessary, nor it is helpful at all. Mechanical ventilation is aimed just to keep the patient supported and alive until something else happens. So your aim at mechanical ventilation should be to keep your patient alive rather than keeping them rather than optimizing or normalizing, let's say, gas exchange or ABG. So understanding these 2 points, that mechanical ventilation is inevitably harmful on one hand, on the other hand, it does not correlate with the extent. There's no improvement in that is linked to normalizing the blood gases. We should understand that mechanical ventilation should always be minimized to necessity to keep the patient alive. Minimized in which aspects? In every aspect. In application in the first place, which means that whenever it is not necessary, then it should not be applied. But if you have to apply mechanical ventilation, then you choose the least invasive, least oxygen, least volume, least pressure, and least duration to avoid harm. Now, having this said, I am satisfied, and I hope you have taken home the most important parts. But if you allow me in the next 20 or 25 minutes, I'll take you very quickly through some essence of mechanical ventilation. We'll talk quickly about the relation between volume and pressure, types of mechanical ventilation, non-invasive and invasive. We'll talk for a couple of slides on non-invasive, then we'll go to invasive, indications, harms, complications, weaning, the essential modes, and like this. So first of all, as we said, mechanical ventilation is always about pressure. So we need to understand the relationship between pressure and volume during mechanical ventilation. This diagram illustrates the lungs. This circle represents the alveoli or the air spaces, and this tube represents the airways or the air pipes. Now, what you want is deliver the volume, the tidal volume, into the alveoli, but you have to go through these tubes in order to do that. Both components exhibit some resistance or elastance to this volume and has to be overcome through pressure. So the pressure you need to fill up the alveoli is called the alveolar pressure. And this has to do with the volume you want to deliver. The higher the volume from the equation below, the higher the volume, the higher the pressure you need. And it has also to do with the compliance of the lung. Compliance is the opposite to the elastance. So the more the compliant the lung, the better. It means it can accommodate to volumes without higher pressures. So it is inversely proportionate. The compliance is inversely proportionate to the pressure. So the higher the volume, the higher the pressure, the higher or the better the compliance, the less the pressure. This applies to the alveolar or what we call plateau pressure component of the peak airway pressure, which is the maximum pressure in the airways. But to get through the tubes to these air sacs, you have to overcome the resistance of the tubes. So as any tube, the airways show resistance to the flow. And this has to do to the flow and the resistance itself. So the higher the flow in terms of liters per minute, which means if you want to deliver the whole breath quickly, then you have to increase the flow, which means more air in a unit time, passing the times. This increases the pressure. Also, the resistance, the higher the resistance, the higher the pressure. The resistance of a tube has to do with its length and its diameter. The longer the tube, the higher the resistance. The wider the tube, the less the resistance. So, remember that during mechanical ventilation, this tube not only represents the bronchi and trachea, but also it represents the endotracheal tube and the ventilator tubings, which makes it really long, and the resistance is significant. A third pressure that has to do with the buildup to the peak airway pressure is the PEEP, positive and expiratory pressure. This is the minimal pressure that we keep during expiration to avoid the alveoli collapsing. We do not want the alveoli to collapse altogether during expiration and then open again during inspiration. So we keep some volume and some pressure inside the alveoli even at the end of expiration. So those three components, the PEEP, which is the residual pressure before we start inspiration, and the pressure, the plateau pressure that is needed to overcome the elasticity, and the other pressure that is needed to overcome the resistance, all together contribute to the peak airway pressure. What we are really interested in always is the plateau pressure, which is the alveolar pressure. And this takes us to the next slide, which is when we stop the flow. When there's no air moving through these tubes, we have stopped the respiratory cycle at the end of inspiration. When the air spaces are filled, we prevent expiration and we do not deliver more volume. This is the pressure that is needed to keep the alveoli open only, because flow here is zero, and multiplication of zero by the resistance will end in zero. So it will only end with the volume and compliance, and PEEP as the parameters. We call this the alveolar or the plateau pressure, and you will find that this is the most important pressure that we are interested in. As we said, mechanical ventilation can be invasive or non-invasive, but the indications are always the same. Obviously, the first category of indications is respiratory failure, whether it is type 1 or type 2. Type 1, you know, is only hypoxic, while type 2 is hypoxic and hypercapnic. Examples of type 1 respiratory failure is community-acquired pneumonia, pulmonary edema, most cases of interstitial pulmonary fibrosis, most cases of pulmonary embolism. So these are the some examples of type 1 respiratory failure. If it goes beyond the ability to support through oxygen only, then it is an indication for mechanical ventilation. Type 2 respiratory failure, the most common or famous examples are COPD exacerbation, acute severe asthma, but also conditions like Guillain-Barré, myasthenia gravis, opiate toxicity, brainstem lesions, cervical fractures would also always end up in type 2 respiratory failure, and it is an indication for mechanical ventilation. Another category of indications to mechanical ventilation is protection of airway. And here, what we really need is to protect airway, not essentially to ventilate the patient, but commonly when we insert an airway, endotracheal tube most of the time, or tracheostomy tube sometimes, then we would complement that with mechanical ventilation. When do we need to protect airways? When the patient is comatose, Glasgow coma scale is less than 9, when he has extensive hematemesis, hemoptysis, or epistaxis, when he has direct trauma to the face or neck, when he suffers conditions like smoke inhalation or angioedema, where airway edema is expected. So all of these are conditions where you would need to have a definitive airway and hence mechanical ventilation. The last and least recognized indication of mechanical ventilation is balancing oxygen delivery versus oxygen consumption. And this happens most of the cases during shock states. Shock is by definition the imbalance between oxygen delivery and oxygen consumption. Oxygen delivery is decreased and oxygen consumption is increased. Mechanical ventilation obviously improves oxygen delivery, but it also decreases oxygen consumption due secondary to alleviating the work of breathing, which can make up to 30% of the whole oxygen expenditure in stress states, and also by allowing us to administer sedatives and or neuromuscular blockades that would also improve the oxygen expenditure in the skeletal muscles. So by applying mechanical ventilation in these conditions, even if the patient is not in respiratory failure and does not need to protect airways, we would try to balance delivery versus consumption. As any therapy, you need to set your goals before starting it. And the obvious goals of mechanical ventilation is maintaining oxygenation and controlling CO2, which we call ventilation. We usually refer to CO2 control as ventilation. Maintaining oxygenation can be achieved through changes in the FI2, which is the percentage of oxygen delivered in inspired air, and through changes in the mean airway pressure, which is the mean pressure throughout the respiratory cycle applied to the airways. the higher the pressure and the higher the FI2, the better usually the oxygenation delivered to the patient. On the other hand, controlling CO2 is usually achieved through the amount of air being inspired in a whole minute. And this is subject to of the tidal volume and the rate. The higher the rate, we call this the minute ventilation, the ventilation that occurs totally in 1 minute. So it has to do with the rate. The higher the rate, the higher the minute ventilation, the lower the CO2, and it has to do with the tidal volume. The higher the volume, the higher the minute ventilation, the lower the CO2. But also not to be forgotten during applying mechanical ventilation is that we have to improve the patient's comfort, and this can be achieved through the choice of mode and by the wise use of sedation and analgesia, and always think of minimizing harm. Knowing that mechanical ventilation is always harmful, you want as a goal to be set to minimize the harm you do during mechanical ventilation. So these are the goals of mechanical ventilation. In view of the indications and goals, we get to choose whether we will start with non-invasive or invasive mechanical ventilation. Obviously, as we said, we want to minimize in terms of invasive. So the obvious choice should be non-invasive mechanical ventilation for all. But unfortunately, it is not applicable to most critically ill patients. And we will see how in a minute. The very famous and well-studied and evidence-based indications of non-invasive are cardiogenic pulmonary edema, COPD exacerbation, and obstructive sleep apnea. However, non-invasive mechanical ventilation is used to treat almost all indications for mechanical ventilation, although not very well established as these three indications. And why we can use non-invasive in other than these indications? We can use it whenever there is no contraindication to non-invasive mechanical ventilation. And contraindications are not indications what shapes the use of non-invasive. You will be surprised at the very little or small patients on non-invasive mechanical ventilation in ICU in face of the praise we always give to non-invasive being better for the patient. However, we don't use it as much because it is contraindicated in most critically ill patients. So any patient who is not able to protect airway, the patient who is not cooperative or does not tolerate non-invasive mechanical ventilation, a patient with any severe condition, hemodynamically unstable, severely acidotic, severe metabolic derangements, is contraindicated for non-invasive. A patient who is not able to clear his own secretions, or obviously a patient who has facial trauma or burn. All these are some of the contraindications of non-invasive mechanical ventilation. However, if there's no contraindicated, and even in indications other than the three I just cited, then it's worth trying non-invasive in most cases. I won't say all cases. Complications of non-invasive include pressure sores on the face, claustrophobia in some patients, abdominal distension, and the possibility of aspiration. Both lead to impaired nutrition of the patient. Sorry, and many others. But the most important complication of non-invasive, and the main reason we don't use it as frequent as we would like, is delaying intubation through masking of deterioration. This frequently happens in unexperienced hands when you apply non-invasive and then the patient would look better, his ABG or saturation would improve while the patient has not genuinely improved. So the patient is deteriorating and we feel like we've done the job. We don't pay attention well. The patient deteriorates until he arrests when we are not paying attention. So this is the most dangerous complication of non-invasive mechanical ventilation. If a patient is suitable for non-invasive, then it should be tried under thorough monitoring and frequent re-examination and reassessment of the suitability of the patient. If it works, it works. If it doesn't, then you switch quickly and timely to invasive mechanical ventilation. If you choose to go for invasive mechanical ventilation, whether initially or after failure of non-invasive mechanical ventilation, then you need to understand the basic modes of invasive mechanical ventilation. And these are three: pressure control, volume control, and pressure support. I'm sorry. So pressure control and volume control are both controlled modes, which means the breaths delivered for the patient are dictated by the ventilator, not the patient, while pressure support is a weaning mode, and the breath the patient get to inspire are dictated by his own. The patient decides when to start the breath, when to end it, how long the breath takes, and how large the volume is. So we'll start with volume control, also called volume cycle. Cycling means the way inspiration ends and the ventilator switches to expiration. So volume cycle or volume control means that the inspiration ends after delivery of the target volume. You get to set a certain volume, tidal volume on the ventilator, and then the ventilator would deliver this volume. And when it is fully delivered, it ends the inspiration and allows expiration. Here, obviously, you get to control the volume. You cannot control the pressure. You can only monitor and try to limit the pressure, but you cannot control it because it is a product of the volume you are giving. All breaths here are mandatory. They can be assisted, which means asked for by the patient, or controlled, which means started by the ventilator. Whether they are assisted or controlled, both ways they are mandatory, which means the volume is the same, the inspiratory time is the same, and the time at which inspiration ends is the same. So all are mandatory. This is the most popular mode of invasive mechanical ventilation. Comparable to volume control is pressure control. We call pressure control time cycle because it ends, inspiration ends after preset time elapses under a certain pressure. So in pressure control, you get to set the inspiratory time and the inspiratory pressure, so that after this finishes, the ventilator cycles to expiration. It is the same, can be assisted or controlled, and both are mandatory. And it also is a mode of assist control, which means the patient does not get to decide how he breathes. It's a mode for the patient to be maintained on, and it's not a weaning mode. There is no evidence-based difference between pressure control and volume control, although volume control is the best studied, hence the most popular mode for assist control. But there's no difference, actually. Some institutes and intensivists prefer pressure or volume control. You can do whatever you prefer. Only in some conditions there's a preference. The third basic mode is pressure support, and we call this flow cycle. Pressure support is a weaning mode. All the breaths in pressure support are spontaneous, which means the patient start and end the breath. And this is why it's a bridge to weaning, or it's or to extubation. It's a mode of weaning, and it's a bridge to extubation. We call it flow cycle because inspiration ends after the inspiratory flow drops to a preset value that you have set. This is the way the ventilator switches from inspiration to expiration. Opposite to volume control and pressure control, as we said, it's a spontaneous mode and it's the most popular weaning mode. Of course, there are many more modes in mechanical ventilation, but you will find that all of them are uh, um, with some changes to these basic modes. But these are the basic modes and in mechanical ventilation. If you have started or you will start invasive mechanical ventilation, then you need to make the initial settings. First, choose the mode. So it is always an assist controlled mode, never pressure control. You never start invasive mechanical ventilation with a weaning mode. You would always start with volume control or pressure control. Oxygen, you would always start with 100%. Then, based on the patient saturation, clinical picture, and ABG, you can decrease the FI2. As we said, we always want to minimize the oxygen we deliver because there's something called oxygen toxicity, and we always prefer oxygen is less than 60%. PEEP, as we said, is the positive and expiratory pressure, and it is the residual pressure we keep the lungs open through, and it is widely accepted that the minimal PEEP is 5. Some patients may need much higher PEEPs in conditions like ARDS, but most of the time you would initially set your values at PEEP of 5 and then take it further based on the patient's condition, the pressures on mechanical ventilation, and his ABG. Then you get to set the volume. In non-ARDS patients, we start with 8 to 10 milliliters per kg of ideal body weight. But in ARDS patients, we start with 4 to 6 milliliters per kg of ideal body weight. This is evidence-based, and it helps minimize the harm, as we said, that is caused by the mechanical ventilation. I'm sorry, can I have a second, please? I'm very sorry, I needed water. Okay, as we said, you control CO2 through both the volume and respiratory. So obviously, if you are ventilating an ARDS patient choosing less volumes, then you'll need to set your rate at higher rates and vice versa. Generally speaking, you initially set your minute ventilation, which is the product of multiplication of volume by respiratory rate, to 80 to 100 milliliters per kg in a whole minute. So if you, as we said, if you choose less volumes, you'll get to increase the rates and vice versa. After you've done this, you monitor the patient saturation, pressures on mechanical ventilation, development of auto-PEEP, ABG, and most importantly, clinical picture, and then adjust accordingly. These are the famous or popular initial settings of mechanical ventilation. Weaning. The main goal or the dream or what we want of a ventilated patient is in ICU is always weaning, which is the liberation of the patient from mechanical ventilation. So to start with, the first step of thinking of weaning is that the initial cause for which you have ventilated the patient has improved. So for example, if a patient has ARDS and you're ventilating him for this reason, then his oxygenation parameters and X-ray need to have improved before you think of weaning. If this has happened, then you take it to step 2. Step 2 is making sure there are no contraindications for weaning. Any patient who requires high settings on mechanical ventilation, who is showing hemodynamic instability, severe metabolic derangements, inability to protect airway, worsening chest X-ray, high fever, inability to clear secretions, weak cough, and many more conditions, is contraindicated for a trial of weaning. So if the patient has had his initial condition improved and he has no contraindication to weaning, you start weaning. Weaning is the bridge to extubation, and it is the period through which you the patient gets to practice spontaneous breathing so that he can maintain himself after extubation. And on the other hand, you get to monitor and test the patient's ability to breathe on his own. There are many weaning modes, the most popular of which is CPAP plus pressure support, as we said, but also TPs is another mode, SIMV, some other modes, but the most popular is pressure support. So on weaning, we call this a spontaneous breathing trial. When you have switched the patient to CPAP and pressure support, that now he is breathing spontaneously, although he still have the endotracheal tube. So this is a spontaneous breathing trial. Ideally, the spontaneous breathing trial should be between 30 minutes and 2 hours, and during which you monitor the patient's vitals, signs of respiratory distress, pattern of breathing, rapid shallow breathing index, ABG, saturation, everything. And then if he does not deteriorate, if he maintains good oxygenation and ventilation without having respiratory distress, without being very tachypnic, without showing shallow breathing, without showing paradoxical or abdominal breathing, without having wide heart rate or blood pressure differences, then you would say this is a successful weaning trial or spontaneous breathing trial, and you proceed for extubation. Last is the complications of mechanical ventilation, and there are many complications. They include complications of airway and complications of sedation and analgesia. Obviously, not inherently complications of mechanical ventilation, but they are very famous associates, as we said. But the core complications of mechanical ventilation is something called ventilator-induced lung injury, VILI, and this is further categorized to barotrauma, injury due to pressure, volutrauma, injury due to excessive volume, atelectotrauma, injury due to the repeated closure and opening of the air spaces, and biotrauma, and this happens secondary to the local release of inflammatory mediators, causing itself lung injury and an ARDS picture. Also, infection is very frequently seen, and it affects the patient's outcome. Largely is infection, mostly ventilator-associated pneumonia. Now, ventilator-associated pneumonia cannot be totally abolished. It has to do with the number of days the patient spent on mechanical ventilation, but there are some bundles or some protocols that we use to minimize ventilator-associated pneumonia and ventilator-associated tracheobronchitis. Also, a rather newly or recently recognized complication, although very important, is the diaphragmatic atrophy. The diaphragmatic atrophy is found to start very early on during mechanical ventilation, and again has to do with the mode and the time the patient spends on mechanical ventilation and some medications you use. So you can see complications of mechanical ventilation are always there, and they are very frequent, and sometimes the patient survives the initial pathology, but then they pass away secondary to complications of treatment, and mainly complications of mechanical ventilation. This is why we said initially in the goals that minimizing harm is always a goal to be watched for the whole period of mechanical ventilation. The most important thing that you can do for a patient to minimize complications other than careful watching is weaning as early as possible. And this takes us to the last slide. And please, if you have any questions.
Thank you, Dr. Basim. We have a question from Dr. Yusuf. So, mechanical ventilation increased intrathoracic pressure and decreased cardiac output. How can we deal with it in shocked patient?
Very well. This is a very clever question. I avoided at all talking about cardiovascular results. I won't say necessarily complications of mechanical ventilation because these are very, very complicated and it is not necessarily negative. It changes based on the mode, the pressure, but more importantly, the patient's condition itself. So generally speaking, mechanical ventilation does increase the intrathoracic pressure, of course, and this increased intrathoracic pressure is usually negative for patients who have good cardiac function, but positive in most patients who have weak or a picture of congestive heart failure. So how we deal with mechanical ventilation in shock patients? When you are intubating a patient initially, you expect a sharp drop in their blood pressure because of the abrupt switch from negative intrathoracic pressure to positive intrathoracic pressure. So you would always want to make sure the patient is not volume depleted. Sometimes you would need to support them with vasopressors prior to starting mechanical ventilation. After starting mechanical ventilation, it is the lung-heart we call interaction is very complicated, but it is based mainly on careful monitoring on both of the pressures, respiratory function and myocardial function, and adjusting according to that.
And I think, Dr. Basim, we can add that mechanical ventilation is not a modality of treatment, it's a modality of support. So unless patients don't have any contraindication for mechanical ventilation as DNR or do not intubate orders, and if there is indications, he must receive mechanical ventilation. And we should treat the cause of the shock, and not of course, the mechanical ventilation will have the side effect, but cause of shock should be treated. And as I mentioned previously, it's a modality of support, not a treatment.
Thanks a lot. You've said it all. Yes. Mechanical ventilation is like CPR itself. If the patient has no hope to live on, then you do not do CPR because CPR is not a goal itself. It's just means to reaching something. So if you are convinced that the patient cannot survive his pathology, you do not do CPR. The same applies to mechanical ventilation and actually to all kinds of medical interventions. So if there's no goal, the patient, like if the patient is DNR, then you do not apply mechanical ventilation. Sometimes a goal is the relief of distress or the convenience of the patient. So we may apply things like non-invasive mechanical ventilation just to ease on the patient as a means of palliation. But invasive mechanical ventilation, if the patient is DNR, I won't start it.
And Dr. Basim, one more question. Is there any recommendation for COVID that support using nasal CPAP over full mask CPAP instead of going to immediate intubation?
As far as I know, the only recommendation when it comes to non-invasive mechanical ventilation is the full helmet with cushioning. As you all are aware, a main area of debate with this COVID is protection of the healthcare workers. So aerosol production is very important, and non-invasive is highly aerosol generating modality. So generally speaking, invasive mechanical ventilation, oxygen therapy, and high flow nasal cannula are preferred over non-invasive mechanical ventilation. Most recent protocols skip non-invasive trial altogether. If the patient is not maintained on normal flow oxygen or high flow oxygen cannula, then you go directly to intubating. But if you will apply non-invasive, then the only recommendation I am aware of is the full helmet with cushions.
Thank you very much. Really great presentation, Dr. Basim. Thank you very much. And we will move to last session. Next topic is ARDS in COVID-19 patient. Will be presented by ICU Senior Consultant, Dr. Omar Ramadan. Kindly, Dr. Omar, can you share your presentation? Dr. Omar? Dr. Omar? Dr. Omar? So I am apologizing for this gap, and just give us some few seconds to solve this problem. Okay, Dr. Omar, can you hear us? Dr. Omar?
Hello, assalamu alaikum.
Alaikum salam, Dr. Omar. Welcome for your presentation. Dr. Omar, can you hear me?
Yes, Dr. Agultekin, give me 1 minute.
Yes. Okay.
Slides already there, Dr. Agultekin?
Yes, slides are there and it's visible.
That's okay. Yeah, thank you. Assalamu alaikum. Good evening, everyone. I'm Dr. Omar Ramadan, ICU Consultant, King Saud Medical City. Hopefully, I'll cover the topic of ARDS in 30 minutes, inshallah. It is a very big topic, but we'll go for targeted management for patients with ARDS. First of all, what is the definition of ARDS? ARDS is defined maybe 15 years ago as acute onset of bilateral lung infiltrates associated with hypoxemia. After exclusion, cardiac cause for this acute onset bilateral lung infiltrates and hypoxemia. The hypoxemia to define your patients in ARDS as hypoxemic is to correlate between the arterial VO2 in the ABG and the oxygen concentration you are giving to your patient, which we defined as BF ratio. So it's not depending on the arterial oxygen saturation, or not depending on arterial VO2, or not depending on oxygen saturation, but depend on the ratio between the arterial VO2 and oxygen concentration you are giving to your patient. At this time, the defined patient have ARDS, a BF ratio less than 200. And at this time, they have another term is acute lung injury or mild form of ARDS of BF ratio less than 300. So it is this four major criteria for definition of patient of ARDS is acute onset of bilateral lung infiltrates associated with hypoxemia, defined by BF ratio, and we should exclude cardiac cause because patients have cardiogenic pulmonary edema will give the same picture. At this time, we exclude cardiac cause by pulmonary capillary pressure through the Swan-Ganz cluster. If it is more than 18, going with cardiogenic pulmonary edema, less than 18 going by ARDS. So this is a typical picture of patient of ARDS has bilateral lung infiltrates because ARDS is systemic disease. It's not unilateral pathology, it is bilateral pathology. So they modify the definition of ARDS on 2014 or 2011. Sorry, the Berlin definition. They define the timing of ARDS. Previous definition mentioned acute, but this is defined acute mean within 7 days from the primary reason for ARDS. So patient may have pneumonia, then he has worsening of his X-ray, and the fulfilling criteria of ARDS. If it is within 1 week, mean patient is going with the definition of ARDS. Second, they classify the ARDS into mild, moderate, and severe according to BF ratio. Mild ARDS, BF ratio less between 200 to 300. Moderate between 100 to 200, and severe ARDS if BF ratio less than 100. And it is correlated with mortality. Patient, of course, of severe ARDS has higher mortality than patient of moderate ARDS, and of course, less mortality with patient have mild ARDS. This is one of the study published last month for 200 patients in Wuhan, in China. The study was at risk for developing ARDS and for mortality was patient with COVID-19. They found that the patient is age more than 65 has higher mortality and higher possibility of ARDS. Patient with comorbidities like diabetic and hypertensive, they have higher possibility of ARDS and mortality. They found this patient to have temperature more than 39 on admission. Possibility of ARDS and the possibility of mortality will be high for patient admitted with high-grade fever. It is also correlated with laboratory finding. They found the patient have absolute neutrophilia on admission or lymphopenia is correlated with ARDS, but it's not correlated with mortality. So neutrophilia and lymphopenia is with ARDS, possibility is high, but mortality is not correlated with mortality. Then if we'll go to patient have high LDH level, it's also correlated with ARDS and correlated with high mortality. If patients have D-dimer high on admission, this patient high risk for developing ARDS, but with less possibility for mortality. So we'll go to the first question. What is the most common cause of ARDS? It is pneumonia, sepsis, trauma, or inhalation injury? So some of answer going with pneumonia, other going with sepsis. the current most common cause of ARDS is sepsis. Before it's considered pneumonia, but the commonest cause of ARDS is sepsis, whatever the etiology. Maybe intra-abdominal sepsis, maybe soft tissue infection, maybe wound infection. So sepsis, whatever the etiology, is a major cause of ARDS, not pneumonia. So we have a lot of causes for ARDS, is going with pulmonary and extra-pulmonary, going with pneumonia, aspiration, inhalation and injury, then patient with fat embolism, patient with transfusion-related acute lung injury, what's the name? TRALI. It's maybe correlated with any blood products, maybe packed RBCs, maybe fresh frozen plasma, platelets. It's not correlated with the type of blood transfusion or by amount of blood transfusion. Other causes for ARDS may be pancreatitis, patient with inhalation injury, or patient with trauma. So we have two major plans of management of ARDS. This is ventilatory management or non-ventilatory management. The idea of ventilatory management, sometimes we have one patient, his diagnosis as pneumonia, and we started the proper dose of antibiotics, the proper selection of antibiotics, and in spite of good choice of the management of pneumonia, patient is worsening, not because of poor selection of antibiotic, but because of poor ventilatory setting, which induce per se more lung injury, and the patient may have developed worsening of this ARDS. So this is a pressure volume loop. This correlates between the pressure and volume. So the correlation between change of volume as pressure by change of pressure, it is a definition of compliance. So the main pathophysiology of patient of ARDS is that he has poor correlation between the pressure inside the alveoli and the volume inside the alveoli, which means he has poor compliance. So this is an inspiratory limb of pressure volume curve, and this is expiratory limb. This pressure and inspiratory limb divided into three parts depending on the correlation between pressure and the volume. Here, most of the this is a lower inflection point, and this upper inflection point will divide the curve into three parts. The first part of the curve below the lower inflection point, the lung is very stiff. Most of alveoli here in atelectatic stage or collapse status. Here, there is good correlation between pressure and the volume. The more you are giving pressure, the more reflected on the volume of the alveoli. So this is considered the most compliant part of the curve. The more you give pressure, you will have poor response from the alveoli. So in this part of the curve, most alveoli will be in the over distension, and patient at this time will have possibility of barotrauma, surgical emphysema, pneumothorax, pneumomediastinum. So the best part to maintain the volume and the pressure of your alveoli is in the safe window between the lower inflection points and upper inflection point. So the idea of lung protection, that you protect the lung from iatrogenic complication from mechanical ventilation. So Dr. Basim approach, this is a quick statements, but we try to avoid the over distension of alveoli, what's named volutrauma. We avoid that most of our alveoli will be in the stage of atelectasis, and collapse will cause atelectatic trauma, or repeated inflation and the deflation of the alveoli. Patients have release of more inflammatory mediators, what we label it biotrauma. If you keep your patients on for prolonged time on high oxygen concentration, more than 60 or duration more than 48 hours, patients have oxygen toxicity because affect increased oxygen free radicals. All of this ventilatory heterogenic complication lead to what is labeled ventilator-induced lung injury. So patient is worsening because of our poor ventilatory setting. So we'll go to the first line of management of ARDS, that most of patients, once you're base stage of ARDS, we will go by nasal cannula, high flow oxygen, then another breathing mask, then we have high nasal oxygen flow up to 40 liters. Then we can apply a patient on non-invasive mechanical ventilation. At the end, if we'll fail all of this, we'll go direct to intubation of your patient. Then we'll go for ventilatory strategy. As we mentioned, that the main pathophysiology of ARDS, patients have poor compliance. So, which means patients need less volume and less pressure to avoid this iatrogenic complication. And another term of lung of ARDS patient is baby lung, because the lung is small regarding the volume and regarding the pressure. From this pathophysiological point of view, they apply one of the valid studies for 20 years that this applying small tidal volume and decrease the pressure for ARDS patients will improve mortality. So they apply low tidal volume 4 to 6 ml per kg in comparison to tidal volume 1 for 10 to 12 ml per kg. They calculated the body weight of the patient according to ideal body weight. So this is X-ray of one patient, is maybe her body mass index is 50 or 60 and above, or her weight is 250. If we calculate the tidal volume according to her actual body weight, will give her 3 or 4 liters of tidal volume. But if we look to her lung volume, the lung volume of normal patients, maybe the weight is 60 or 70. So we should calculate the tidal volume of patient of ARDS or in general any patient mechanical ventilation is depending on the ideal body weight, which is depending on the height of the patient and gender. So what they found if you apply tidal volume 4 to 6 ml per kg and keep your target of plateau pressure less than 30, patients has better survival rate. Mortality rate decreased from 40 to 32%. So decreasing tidal volume from 12 to 6 ml per kg ideal body weight improve mortality of those patients. And this is one of the studies show improvement of the outcome. Then we'll go to second question. 28 years old patient with ARDS, secondary to severe pneumonia. Patient ideal body weight is 70, his tidal volume 420, and his BB's respiratory rate to 18, BB 12, patient FI2 0.8 now. ABG show BH 7.28, BO2 76, PCO2 57, saturation 92, and bicarbs 18. So this patient, what we'll do for the current status? So we'll keep the same respiratory setting, increase respiratory rate to 22, increase tidal volume to 500, and give 100 sodium bicarb. Before answering this question, you should search where is the problem with this patient. Is oxygenation, ventilation, or the problem ventilation or oxygenation? So to give you a clue for the correct answer. Let's go for the answer. Second remaining. So we have till now majority answer to increase the respiratory rate to 22. Then others, second answer is to increase tidal volume to 500. Then other give sodium bicarb. The least answer 5%, 13%, 5% give the correct answer, which is keep current status. So if we review these blood gases, patient before his NFI to 100% and the patient says desaturated, then now patient his BF ratio BO2 76 and FI 2.8 means that BF ratio is less than 100, severe ARDS. But what is new for this patient that he starts to retain CO2 and has element of respiratory acidosis, but saturation is maintained. So if we give 100 ml of sodium bicarbonate, then this sodium bicarbonate will be metabolized to CO2, so it will increase the CO2. Increase tidal volume, this will go against our theory of decreasing the tidal volume, and we have evidence based that the decreased tidal volume will improve mortality. So if we calculate the ideal body as a target tidal volume here, we'll multiply 70, multiply by 6, will give 420. So if we go to increase tidal volume, it will be against the lung protective strategy. Increase the respiratory rate, it may really wash some of the CO2, but the more the increase the respiratory rate, it decreases the time for expiration, which may be minimize the duration for expiration. Why we have to keep the current setting? Because this patient, if we calculate his tidal volume, it is 420, and this patient now in the safe window, which means that this strategy improve mortality. So we have to accept this high CO2, and we have to accept this respiratory acidosis for the sake of lung protection. What we label of this one is permissive hypercarbia, which means for the that we should accept patient have respiratory acidosis, retain some of CO2 for the sake of lung protection, because it was we have evidence based that lung protective strategy improve mortality of patient of ARDS. So at what level we should accept the patient has retaining CO2? Before we accept up to 7.25, but now we can go to the level of 7.18. So the target is not the level of CO2, the target is the pH. We can accept pH up to 7.18 for the sake of lung protective strategy. But we have absolute contraindication for patient with permissive hypercarbia, for patient with ARDS, if patient have any reason for increased intracranial tension. So patient have infarction, patient have massive ICH, patient have meningoencephalitis, patient have status epilepticus, any reason for possible increased intracranial pressure, we shouldn't accept hypercarbia, because increased CO2 will cause cerebral vasodilatation, increase cerebral blood flow, which lead to increased intracranial pressure. We'll go to the second part of basic mechanical ventilation for ARDS is the BEEP. BEEP is the abbreviation of positive index expiratory pressure. The idea of why applying BEEP will improve oxygenation, because if it will prevent atelectasis and collapse. This is one of the reason. Second, if you keep some of the air and keep your alveoli inflated at the end of expiration, it will give more time for gas exchange during inspiration and during expiration. But we should put in our mind that if you increase your BEEP, it will compromise your hemodynamics, because increased BEEP will increase intrathoracic pressure, will decrease the venous returns, decrease cardiac output, decrease mean arterial blood pressure, and decrease perfusion. So before going to increase your BEEP to improve oxygenation, put in your mind that the volume status of your patient. So don't increase your BEEP in hypovolemic or intravascular volume depleted patients. So what is the optimum BEEP? There is no definition for optimum BEEP, but we'll go for clinical definition. Clinical definition is a BEEP that improve oxygenation would help you to decrease FO2 requirement without compromising the hemodynamics of your patient. Usually we are going by BEEP to 12 to 16 most of ARDS patients, but of course what is fit one patient will not fit the other patient. So some patients respond to 12, the other if you increase BEEP to 16 oxygenation will be improved, but some patient will decrease depending on how much of your alveoli is still in need of more recruitment or more BEEP. Second, does high BEEP improve mortality in patients with ARDS? Of course, no. ARDS mortality will not improve by increased beep. Increased beep will decrease maybe duration mechanical ventilation, decrease ICU stay, but will not improve mortality. So our patients after 12 hours, patient FiO2 requirement increase from 80% to 100%, beep cell 12, tidal volume the same, respiratory rate 20, plateau pressure 32. Patient have pH 7.18, PO2 55, BCO2 59, bicarb 18, and saturation 85. So this patient is worsening hypoxemic. BF ratio before 90, now BF ratio is 55. So what is the next step? Increase beep to 20, prone position, increase tidal volume to 550, and or you can choose to put your patient DNR. So we have 62% of our colleagues get the correct answer, which is proning. Let's give increased beep to 20. Let's to increase tidal volume to 550. So this patient, we can label him as has refractory hypoxemia. That patient already we give him the maximum of conventional mechanical ventilation, BO2, FiO2 already 100% and beep was 12, and patient still desaturated. So, and the already plateau pressure is 32. So increasing beep to 20, of course, maybe improve oxygenation, but the issue of this increasing more beep, it will compromise the hemodynamics, one issue, and compromising the hemodynamics will compromise the perfusion. Patient will have ventilation perfusion mismatch, will have more shunt and more hypoxemia. Again, if you increase your beep, your plateau pressure will be increased, and will, of course, our target of conventional mechanical ventilation to keep your plateau pressure less than 32. Increased tidal volume will go again to theory that we should increase the tidal volume because we apply low tidal volume strategy. Prone position is one, of course, the risk is cerebral for ARDS. So this patient have refractory hypoxemia, so we'll go to another plan of management which under the etiology of rescue therapy. So if patient have refractory hypoxemia, we have still many lines of treatment we can apply for our patient. The first is prone position, second ABRV mode, third high frequency ventilatory ventilation, nitric oxide inhalation, ECMO. Then we have another line that you can increase your beep for 40 centimeter water for 40 seconds to recruit some of the alveoli, but be cautious about the intravascular volume status of your patients and the hemodynamics. So when to consider your patient to go for rescue therapy. We don't have official definition, but we may consider that if patient have PO2 less than 50, on FiO2 more than 70, patient have refractory hypoxemia, patient already increase your beep, and you should rule out reversible cause. At this time, you should consider your patient have refractory hypoxemia and the refractory to the management of conventional mechanical ventilation. Before going for rescue therapy, you should be sure of 3 or 4 causes. First of all, patient may be hypoxemia because he has low cardiac output status in the form of cardiomyopathy, for example. So you should check your cardiac status of your patient, doing for him echo. Then you can optimize your antiferrin medication. If he's hemodynamic stable, you can give him ACE inhibitor, diuretics, small dose beta blocker. If he's unstable, you can give him inotropic support to improve the contractility of your patient. Second, the opposite. Some of your patients may have intravascular volume depletion because most of our ARDS patients, we try to keep them toward negative balance, so giving them Lasix and give them high dose diuretics to keep them toward negative balance. If your patients, if we keep him severely intravascular volume depleted, it will compromise his perfusion, which lead again to ventilation perfusion mismatch and increase shunt fraction, and the patient will have hypoxemia. Third, most of our patients of ARDS, they have dilated right side or right ventricular strain, right ventricular failure. So we should optimize the right-sided function of your patient by giving him inotropes in the form of, for example, dobutamine or any dilator like amirinon to improve the right-sided function of your patients. The fourth, you should keep your patient well sedated, and sometimes you need to give him neuromuscular blockades, either boluses or infusion according to the response of your patient. So you should maintain the left ventricular function, right ventricular function, intravascular volume of your patients, and optimize the sedation and the muscle relaxant before going for any rescue therapy. So how come the prone position improve oxygenation? We have a lot of theory about prone position. First and simple is proning your patient will improve the drainage of secretion. Second, it will help to improve of the ventilation perfusion mismatch, which happened for ARDS patient. It means that area of good ventilation and aeration will receive more blood flow, and the area of poor ventilation and aeration have less perfusion. So we'll match the perfusion and the ventilation with each other, which will decrease the shunt fraction and improve oxygenation. Third, if we look to the cardiac shadow here, in supine position, the cardiac shadow is resting on the lung tissue. But if we prone our patients, the weight of the heart is resting on the sternum with the bony part. So this is one of the theory is why patient is improve oxygenation in prone position. Then we'll go to the second study that show improved mortality for patient of ARDS. This study under the name of PROSEVA study. It is done a few years ago, and they compare between patient in prone position and patient on supine position. They found that mortality decreased from 33% to 16% if we prone our patient. So we have protocol for proning of our patients. Usually we keep our patient proning for 16 hours. Not even patient improved, we should put him again supine for 8 hours. Then before proning our patient, should maintain intravascular volume state of your patient, because once you prone your patient, you lose the compensated sympathetic mechanism. So your patient liable for hypotension, hypoperfusion. So our patient should maintain intravascular volume status of him. Then we should maintain a small dose vasopressors. Then we should prepare 6 persons to prone your patient. One will take care of the airway, tubes. One will take care of the lines and the ICT if patient have ICT. 2 persons on the right, 2 persons on the left. Then we'll go to, then we'll keep your patient well sedated and giving him muscle relaxant. Then we'll prone him and take care of the pressure point in his forehead, in his eye, nose, face, chest, abdomen, genitalia, knees, and they should take care of his upper limb not to be overstretched to avoid brachial plexus injury. So as we agree, the patient should be well sedated, getting muscle relaxant, maintaining his intravascular volume status, maintaining his hemodynamics, and we should keep him supine again after 8 hours. So this was the ventilatory management for ARDS. We have 2 points, non-ventilatory management we should discuss in the coming few minutes. First is steroids. Are our patients with ARDS will get benefit from steroids? This is a major debate maybe for the last 30 years about if really any patient with ARDS we should give steroids. Some of the study recommend, others they said don't recommend, but the agreement that we shouldn't give our patient with ARDS, whatever the etiology, steroid, and this is not in our regular protocol. Then we'll go if sick patient has viral pneumonia and he has developed ARDS, it found that patient who are giving steroids, mortality increased. So if patient have viral pneumonia, whatever it was, H1N1 before or MERS-CoV, we shouldn't go for steroids. This is our own study in King Saud Medical City in 2019, run by Dr. Mahdi and other team. About the H1N1 patient, we have about 135 patients at this time. It shows that patients who receive steroids, mortality increased by 50%. So patient with viral pneumonia, we should avoid using of steroids. This study done in few patients in China for COVID-19 patient. They found that if you are giving your patients steroids, they found patients have better survival rate. But this study already done a less number of patients. So they recommend that we can give steroids for patients with COVID-19. Then we'll go to the consensus agreement. They said if patients have mechanical ventilation and they has ARDS, they suggest to give systemic corticosteroid. This is a general recommendation. But there is more wise people said this is study already run for a few number of patients, and we shouldn't go without more randomized controlled trials and more number of patients. So they give only suggest if you want to go, you can give steroids for patient of ARDS. But if your patient he has COVID-19 pneumonia, but you don't have ARDS, they suggest not to use systemic steroid. So they suggest to give steroids for patient have COVID-19 and he has ARDS, with of course the precautions because not yet evidence-based by large randomized controlled trials. But they said we shouldn't give steroids if patients you don't have ARDS. Second part of the ARDS management is the fluid management. Most of our recommendation as ICU physicians that try to keep our ICU patient who have ARDS toward negative balance. So sometimes we give them bolusoplastic, sometimes we start Lasix infusion. Even some patients, if he has mild acute kidney injury, we go for CRRT to remove fluids and we can control his volume status by using the CRRT. So this is one of long time study before it's named FACT study to compare between patients of ARDS who are giving their more fluids or another group that we are conservative in giving their fluids. Of course, if we give our patient diuretics and we restrict out fluid intake, patients have better oxygenation, ventilation, but it will compromise the intravascular volume status of your patient, may compromise the renal blood flow, then patient may develop worsening of his renal profile, and some of them will develop acute kidney injury. In the opposite, if we give more fluid to our patients, kidney will be happy, patient have better perfusion, better intravascular volume status, better urine output, better renal profile, but of course it will compromise the oxygenation of your patient. So you have to choose. Of course, the patient have ARDS, we have to keep our patient toward negative balance for the sake of the lung. And of course, the patient have acute kidney injury, we can handle by CRRT maneuver. Then we'll go for the conclusion of ARDS. A patient, of course, has COVID-19 and then develop hypoxemia. So we should assess patient need intubation or can maintain by non-invasive methods. So we can apply face mask. If not responding, we can apply high flow nasal cannula. Of course, our consideration here is because high flow nasal cannula, non-breathing mask, or non-invasive mechanical ventilation, all of this may expose other patients and may expose the healthcare provider to more hazards for COVID-19. So if you think to intubate your patient, you should intubate him immediately with taking your or precautions of PPE. Our target of ARDS is keep saturation between 92 to 96, and we can accept even less than to 88%. Then if patient have ARDS, if patient have mild ARDS, we apply lung protective strategy. We should rule out bacterial infection. Our target saturation 92 to 96. We should be conservative in the fluid management. Empirical antibiotics should start it if you think patient has secondary bacterial infection. Systemic steroids, we agree that patient have ARDS, we may to give, but we need to have more evidence base. Patient have ARD, higher moderate to severe ARDS, we increase BEEP. We can give patients more bolus of muscle relaxant, keep him well sedated. We can use the traditional recruitment maneuver, which increasing BEEP, for example, 40 centimeter water for 40 seconds, provided his intravascular volume status. Patient is not improving and we'll go for rescue therapy. We'll maintain our patient prone position for 16 hours. And then we should maintain patient in prone position in muscle relaxant. Most of the time we are using muscle relaxant infusion. Then again, we'll go for the debate of steroids. Then if patient is not responding to prone position, muscle relaxant infusion, and patient still hopeful and he's young, we can consider this patient to activate the ECMO service. But of course, we should be cautious about which patient we should apply for ECMO, and we should choose a really hopeful patient because we have limited resources, especially in the surge of huge number of patients. We should really keep ECMO for certain selected patient. And remember, one point about ECMO is a contraindication for ECMO, which is coagulopathy, bleeding tendency, severe thrombocytopenia. This is the main concern for ECMO. Thank you so much. Any questions?
Thank you, Dr. Omar. Please, you can raise your hand or you can put the question in the chat. Thanks again, Dr. Omar. I think there is no questions. It was so clear lecture.
Thank you so much.
To all audience, I want just remind that tomorrow there will be a webinar, Defeat COVID-19, presented by Dr. Wasim, Dr. Salman, and Dr. Mohammed, ICU consultants. So tomorrow at 8 p.m. it will start, and it's already announced in the group. And the day after tomorrow, it means on Wednesday, we'll continue our third session. And if any queries, you can chat with us in the group. Thank you very much and good night. Thank you to everyone.
Thanks so much.